Dr. Nishant.
So thank you, sir. I'll just share my screen.
Yeah. So it's the most important aspect, surgical instruments overview. So he's going to talk about the instruments for 40 minutes.
Yeah. Good evening, everybody. I hope I'm audible. I'm Dr. Nishant, and today we'll be discussing surgical instruments. Basically, this is a part of your viva OC after your practical examination, after your major and minor cases. So this will be the way we go about this presentation. First, we're going to talk about parts of an instrument, then the various grasping instruments, the retractors, the cutting instruments, then miscellaneous instruments, and then finally a bit about laparoscopic instruments. So what is expected of you in the exam? Once the examiner opposite you tells you to pick up an instrument, the first thing.
Yes, sir. Just let me stop you. Let the students, if you have any doubts, any questions, please put it in the chat box and we will answer all those questions as we go along. Sorry to stop you, Nishan. Carry on.
Yeah. So the first thing when the examiner tells you to pick up an instrument, first name the instrument. Okay. For example, this is an artery forceps. You say this is a Kelly's artery forceps. Hold it like how you hold it during surgery. And then what is the material it's made up of? What are the various parts of the instrument? How is this instrument sterilized? And finally, the use of the instrument, as in what surgeries you're going to use it for, and so on and so forth. And if you know a bit about specialty of the instrument or historical importance, but like I said, the last 2 points come into picture only after you've got the first 5 right. So let's directly jump into the parts of an instrument. We know that the tip has what we call the blade or the jaw. Then you have the joint. Then you have 2 long levers. This is called as the shank. And finally, the handle. The handle part consists of a ring, and few instruments have ratchets, few do not have a ratchet. Now, the ring in the handle, one ring is where your thumb goes, the other is where your ring finger goes, your middle finger supports it, and your index finger is over the joint in order to stabilize the instrument. Okay, so this is how you hold any surgical instrument. Now, the role of the ratchet is to make the instrument self-retaining. For example, you can see that now I've locked this instrument, I've put the ratchet, and you can see that the instrument holds in place. I don't need to add any extra force to keep both the jaws in a position. Now, the same thing, if I don't lock the ratchet, I've unlocked. The minute I leave this, the instrument opens. Okay, so that is the role of a ratchet. It makes the instrument self-retaining. Now, coming to the types of joint, one is a box joint, the other is the screw joint. In box joint, one half of the instrument goes through the hole in the other half of the instrument. If you can see, I don't think it's very clear in the image, but anyway, you'll see that one half of the instrument is through the other. Now, the advantage is that the 2 jaws will oppose or come against each other perfectly. All right, they sit right across each other. So they help you grasp or grab the tissue properly. It doesn't slide around like this. All right, so there's no slipping of tissues. Once you grab something, you know for a fact it's held well. Now, the disadvantage being the small crevices where you can see in the box joint is where the suture can get stuck, especially in a needle holder, and it can irritate you a little bit. Now, coming to the screw joint, you can see that there is a screw here. Okay. Similar to the screw, what you can see here. Here you can see that the instrument doesn't go one inside the other, but it's where the blades slide over each other. All right. So this is more or less used for cutting instruments where you want the instrument to slide over each other and cut. You don't want to grab something with the scissor, but you want to cut something with the scissor. Now, again, the disadvantage being it's a screw joint. So the joint can become loose. The screw can become undone. So the instrument might not glide across each other perfectly and it might not cut very well. And when the screw is loose, again, a suture can go get stuck there and cause a little bit of trouble. Now coming to the serrations, there are transverse serrations and longitudinal serrations. Transverse serration is when the serrations are perpendicular to the axis of the instrument. If this is the axis of the instrument and the serrations are perpendicular, you call them as transverse serrations, and they're more or less traumatic in nature. Now, for example, the advantage is if I grab a tissue and the serrations are like this. So even if one serration slips, the next one will hold. If this also slips, the next one will hold. This also slips, the next one will hold. So you know you have a very good grasp over the tissue. It is something similar to having multiple humps on the road as against a single hump. You tend to slow down a lot more when there are multiple humps. So a transverse serration indicates that it's a traumatic forceps. Whereas Longitudinal serrations. This is normally seen in a bowel clamp. All right, a bowel clamp, you're going to see longitudinal serrations. Here, you don't expect to grab. You only expect to occlude the lumen. You're not trying to lift up the intestine with this. You're only trying to occlude the lumen. So any instrument without serration or with longitudinal serrations are invariably relatively atraumatic. I honestly believe there's nothing called atraumatic in surgery, but they're relatively atraumatic. So let's move on to a few grasping instruments. So for the first two, I'll tell you how you're going to answer in the examination, and from the rest, we'll just pick up the speed and go on. So first one is a Kelly's artery forceps. Okay, they can either be a long artery forceps, a medium artery forceps, short artery forceps. They can either be curved or straight. So the minute you pick it up, you hold it in your hand, you tell this is a Kelly's medium-sized curved artery forceps. It has a jaw, it has jaws, it has a box joint, it has a shank, they have rings and ratchet. It has transverse serrations. It is made up of stainless steel and it is autoclaved. It's sterilized by autoclaving and it's used to grasp tissue. Now, the easiest way to remember what the material is and how to sterilize it is by a simple technique. Any metallic instrument that you come across in surgery is always made up of stainless steel. All right. If you don't know what it is, if it's a metallic instrument, blindly say stainless steel, and 99% of the times you'll be right. And if it's something which is made up of a tube, like a Riles tube or a corrugated rubber drain or an abdominal drain, say PVC, blindly say PVC, and invariably you'll be correct. Medical grade PVC will be correct. Now coming to the sterilization technique. Any metallic instrument that is stainless steel is sterilized by autoclaving it, except for a scissor. Sharp instruments, if you autoclave them, they tend to become blunt. So this you're going to sterilize by ETO. Otherwise, any other instrument, you're going to say stainless steel and sterilized by autoclaving. And when I talk about tubes, any material you don't know about it, tell that it is made up of medical grade PVC and it is sterilized by ETO. Obviously, you can't autoclave them, otherwise they tend to melt. Okay.
Nishan,
So that
one thing, in
yes,
the
sir.
current scenario, are we going to tell people about ETO sterilization?
No, sir, I'm not going into sterilization, only about an introduction.
Should we even mention ETO sterilization?
Yes, sir. We do
Because
ETO.
nowadays there is more inclination towards plasma sterilization. ETO has its own implications.
Yes, sir. At least for the exam, if they say ETO, I think it is acceptable for them.
Definitely not autoclave.
Yes, sir. That was the point.
Okay.
All right. So now we have already discussed most of the points. The last 2 points, this is used to grab tissues in order for you to suture, and obviously to hold suture materials, the tip of the suture materials, and it's also used for dissection. All right. Now, the last bit about the artery forceps, you need to know the difference between a straight and a curved artery forceps. Obviously, anything which is curved is made so for a reason, because you can visualize the tip. But at the same time, the disadvantage being, I'll just give you an example. If this is a narrow opening and this is a curved forceps, it might not go in. All right. Whereas a straight artery forceps can go all the way inside and grab the tissue. A straight artery forceps can go into a narrow space at the cost of visualization. Whereas in a curved artery forceps, you get better visualization, but might not be the best of the instrument in narrow areas. So this is a right angle artery forceps. The rest of it will remain the same. The jaws, the joint, the material, the sterilization. The speciality is that it has it has a right angle at the tip. The advantage is that you can see what you're catching very clearly. And the most important point is you can get around the structure very easily. Like for example, assume this is a tubular structure and this is a right angle. If I go around it, just look at the position of my wrist. By doing just this much, I'm all the way around my finger with the instrument. Whereas if I try to do the same thing with a curved artery forceps, please see that I have to go all the way around to make sure that the artery forceps comes all the way to the opposite side. So right angle forceps will help you get around the tubular structure much more easily than a curved artery forceps. Then we have the Cocker's forceps. I'm sure all of you know. This looks like an artery forceps, except that it has a sharp tooth at the end. So it is severely traumatic and should only be used on the specimen side. Okay, don't put this on any structure which is going to be retained inside the body of the patient. So normally you've seen gynecologists use this when they're doing hysterectomies. And for surgeons, probably when you're doing a bowel resection, if you're run out of bowel clamps, you can use the bowel clamp for the patient side. And for the specimen side, that is the bowel which is being resected, you can put a Cocker's clamp to make sure that it doesn't slip off and there is no soil or spillage of the contents from the intestine. Oh, and the speciality of the Cocker's forceps was that it was actually introduced for the thyroid surgeries, where they used to clamp the superior pedicle of the thyroid. It's no longer being used, but just for historical importance. Then we have the Ali's forceps. This is recognized by the fact that it has teeth, and these teeth in one jaw sit in the groove which is specifically made for it in the opposite jaw. All right. So again, this is a traumatic forceps. It is used to hold fascia and aponeurosis, more or less used commonly in our hernia surgeries. But the thing that you need to remember is it should not grab onto skin. We have a tendency to put Ali's on the skin and lift it up. That's because when you pull, it can cause severe abrasions on the skin. For a patient, it doesn't matter what you have operated on the inside, but what matters is how the skin looks on the outside. So if you end up with a lot of aberrations there, it might not sit very well with the patient. Next, we have the Babcock's forceps. This is still a traumatic forceps, but it's relatively atraumatic. It's slightly less traumatic when you compare it to the other instruments. The specialty is that it doesn't have teeth, but more important is it has a bulge at the terminal end and holes. Now, the importance of this bulge is so that you can hold soft tissue inside this, and the hole inside this allows the soft tissue to bulge out when you hold it. So it will prevent crushing of the tissues. It's giving the tissue some leeway for it to come out and prevent crushing. So this is used to hold soft tissue, intestines, tubular structures. In our hernia surgeries, when we're holding the cord structures, we pick it up and manipulate the mesh underneath, especially in our open hernia surgeries. Then we have the Lane's gland holding or the lymph node holding forceps. It looks almost similar to Babcock's forceps, except that it has teeth in the front. Now, the easiest way to remember it is it looks like the head of a lion. So that's the reason I remember it as a Lane's gland holding forceps. Again, here it has a bulge and a hole or a hollow area there, which allows the lymph node or the tissue to expand out, preventing crushing. It's very important when you're excising lymph nodes that you excise it in toto and you don't crush the lymph node, because we all know that when we send crushed out lymph nodes, the pathologist always says you won't get the diagnosis what you're expecting. So you always need to send the lymph node in total, and you don't want the capsule to be ruptured. Next, we have the ramp, please. Yes, sir.
One thing for the students, the rachet is there just to hold the tissue, and one click is sufficient. You don't have to hear the noise or crick as if the entire 5 jaws of the rachet is utilized, because one click is sufficient to hang on to the tissues, and tissue respect is extremely important. The more rachets you use, the more trauma it will cause, even though it is an atraumatic forceps.
Thank you, sir. And this is the Rampley's sponge holding forceps, which I'm sure all of you would have seen. It has transverse serrations, which indicate that it's a traumatic forceps. I'm sure all of you know what it's used for, to hold a sponge or a swab in order for painting before surgery, in order to maintain asepsis. The alternate use is we don't do open cholecystectomies a lot nowadays, but it is used to hold the infundibule of the gallbladder and retract it downwards and outwards in order to open up the calyx triangle for better dissection. Now, this is slightly peculiar. This is a towel clip. One of it is called Mayo, one of it is called Doynes. The common confusion is which is for which. The easiest way how I remember it is Mayo. If you eat a lot of mayonnaise, you tend to become big and fat. So the bigger of the forceps is called as Mayo's towel clamp, and the smaller one is called as Doynes. Other way to remember it is you look at this towel clamp, you make it straight, it looks like a small letter D. So even that's another way of remembering that the name is Doynes. The towel clip, as we all know, is used to, it has 2 teeth at the tip. This is used to hold the sterile drapes in place. Make sure you don't catch the skin underneath, otherwise the patient will have puncture wounds there, which can be extremely painful. Now, the difference from a Doynes towel clip is that it doesn't have a joint, it doesn't have a ratchet, but instead it comes with a preloaded spring action. It's a clip. It's exactly like your forceps. It has a preloaded spring The minute you press it, it opens up, and the minute you release the pressure, it closes. So that's about the towel clips. Finally, then we move on to the intestinal clamp. Like we discussed, the intestinal clamp has longitudinal serrations. So it's a atraumatic or relatively atraumatic forceps. Now I want you to see this. I hope you can see my finger through the hole. This is in spite of closing the ratchet. In spite of closing the ratchet, you can see my finger still there. That means there is still a gap here, which basically means that you don't want the tissues to get crushed. You only want the walls of the intestine to occlude against each other. So this is only used for occlusion of the lumen and not the blood supply. Second thing is, don't close and try to pick up the intestine with this and come to the surface of the wound. The intestine will end up slipping out of it, and you'll end up having soiling of the intestinal contents inside the abdominal cavity. The rest of it will remain the same as we have discussed about the other instruments. Now let's move on to retractors. Now a little peculiarity about, you need to know a few points about the retractor. The first is the terminal bend. Now the advantage of having a terminal bend is that it hooks onto the tissues and doesn't allow it to slip. If there is no terminal bend and it's straight, even with a little movement of your hand, it will slip out. Second thing is, one more thing that you need to know is, first year of post-graduation is called as FRCS, that is Fellowship in Retraction and Cutting Sutures. So unless you know how to retract properly, they won't allow you to go to the second year. Now, you observe that this retractor has a broad handle. Most of us assume that this ring and the broad handle is to put our finger and grasp, which can't be farther from the truth. So just look at this. If I grab hold of this, if this was a single line without any design, if it's a single line, I hold this and grab, you can see that the instrument is slipping. But if it's a broad handle where I'm using the entire hand to hold this and I pull, I have a good grip. It's not slipping. So please understand, retraction is a tedious procedure. So you need to have a good grip to hold on to it. Now this entire thing was made up of solid steel. It would have made it even more heavier and more difficult to retract. That's the reason there are holes here to make it hollow, and they reduce the weight of the instrument, and that's how you retract. So this is a Langenbach's retractor. This was initially used for retraction of the liver. Nowadays, we use it to retract the superficial structures, such as in a hernia surgery. Then we have the Morris retractor.
The thing is, people must understand when they select by retractors, they must think that the length and the width of the blade, that ratio must be 3:1. Anything different from that, either it will be too long or too short.
Okay. Yeah. Then we have the Zerni's retractor. In the Zerni's retractor, on one end, you have how it looks like a Langenbach. Then you have a hollow structure in the middle, and then you have two slits at the other end. Now, these slits allow you for better visualization. All right. So if there is some bleeding happening there, imagine you put a Langenbach, the bleeding gets hidden behind the retractor. Whereas with the Zerni's retractor, because it's open, you can actually see the bleeder catch it. Or if you're trying to close the fascia, again, this retraction will help you look at the edge of the fascia when you're suturing it. Now we have the Morris retractor. Now the Morris retractor is almost similar to the Langenbach. So what they realized in open cholecystectomy was when they used the Langenbach retractor, because it was very narrow, the liver used to flop around this. That is why they came up with the Morris retractor, because it's more broad and they can hold back a bigger area of the liver when they're retracting. And with a little change, you can see that there is a small concavity on the top. So this concavity allows for manipulation. If you're suturing something, gives you a little bit of extra room as compared to having a flat surface. Then we have the Doyne's retractor. Right? The Doyne's retractor it has a curve even on the side. This is used to retract the urinary bladder, and this curve sits on the pubic symphysis. So this is used in pelvic surgery. The Morris retractor is used in upper abdominal surgeries. So how do you differentiate the two? Both of them have concavity on the top, but when you look from the side, a Doyne's retractor has a curve, a Morris retractor is straight. Other way of looking at it is lift the instrument like this, make this a circle, it looks like a small letter D, it's a Doyne's retractor. And our most favorite retractor, this is the Deaver's retractor. It has a hook at the end. This allows you to give you good grip, and it has a curve here. It not only can retract the tissue laterally, but with a little movement of your wrist, you can even retract the tissue superiorly. So this is used for retracting deeper structures. So till now, whatever retractors we discussed are usually to retract the superficial structures. The debus is used to retract the deeper structures. Now, for theoretical purpose, you need to know about this. This is called as the Balfour's self-retaining retractor. This is usually comes with the Doyne's retractor. Now, when I say self-retaining, it obviously means that you need one or two less assistants during the surgery. Now, the same thing, you just need to know the names. This is called as the Dennis Brown ring retractor, and this is called as the Kirschner ring retractor. Now, coming to cutting instruments, there is a basic difference between a surgeon scissor and a tailor scissor. In a surgeon scissor, you'll see that the blade part of the instrument is actually small when compared to the shank and the handle. Whereas in a tailor scissor, the blades are long when compared to the shank and the handle. And most of the times when the scissors what we use in surgery are curved, the straight scissors are invariably used for cutting sutures. So in surgery, whenever you're using curved scissor, it's because it needs good visualization. Cutting is a irreversible step. So think 10 times before you cut anything. So cutting is an irreversible step. So you need to see what you're cutting, and a surgeon cuts with the tip of his scissor, whereas a tailor cuts from somewhere deep in. For him, he just puts the scissor and one right whack all the way through he'll go. But a surgeon can't do that. He has to go bit by bit and cutting with only the tip. Now, again, in scissors, we have the Mayo scissor and the Metzenbaum scissor. It's very easy to get confused as to which is which. Same funda, apply it again. Big, heavy scissor, which are well built, you call them Mayo. The thin ones are called as Metzenbaum scissor. They have blades, they have a screw joint, they have a shank, they have ringers, but they don't have ratchet. Okay, that is the one difference that you need to say when you're against a curved artery forceps. Now, like we said, you should not sterilize this with autoclaving because they become blunt. So either say Sidex or ETO, or like Sir said, even plasma sterilization can be done. So a Mayo scissor is for cutting dense tissue and for cutting sutures. This is a Metzenbaum scissor. You can see that it is thin and long, and this is used for fine dissection. This is a suture cutting scissor. You can see that the tip is slightly curved upwards. That is so that you can hook beneath the suture, pick it up, look at it, and then cut it. Now, this is one thing that you need to know when it comes to the jaws of a needle holder. This is a needle holder. You can see that the jaws have crisscross serrations. They're neither transverse nor longitudinal. The reason you have crisscross serration is so that you have a good grip on the needle. All right. You don't want the needle to be wobbly when you hold it with a needle holder. When you're going through the skin, you need a firm grip over it. And that's the reason you have crisscross serration, so that the needle doesn't flip inside the needle holder. Now, the second thing which most of you would have missed is that there is a small slit in the jaws of the needle holder. It's a very fine slit, but very important. So just assume the needle is a curved structure. And if you try to compress it between two flat jaws, obviously the curve of the needle will become a bit flat. You're destroying the curve of the needle when you hold it between two flat structures. That is where this slit comes. So the slit will accommodate the curve of the needle when you're grasping it. All right. So if this is a slit, this is the curve of the needle. It'll sit inside the slit, so to prevent that straightening of the needle and weakening of the needle. This is an Adson's forceps. You can get it with tooth, without tooth, and it has certain serrations on it at this area. This is where the surgeon holds on it. The reason for the serrations are there is so that you get a good grip. This is to hold fine, thin structures. So if you have with tooth, they're considered traumatic. If you have without tooth, they are considered atraumatic. Then you have the tissue holding forceps or the thumb forceps. Again, you can have it with tooth or without tooth. And all these tissue holding forceps come with a preloaded spring action. You can see that when I press, it compresses, and when I release, it opens. So this is called as a preloaded spring action. Now, a few things about organ-specific instruments. This is a Joel's thyroid retractor. It has two towel holding clamps, something like that on the side, and a circular knob which rotated opens up. So these clips are to be put on the platysma. So this is used to raise subplatysmal flaps. If an examiner gives you this, it basically means that he wants to ask you questions on thyroid and thyroidectomy rather than the instrument per se, and that is where the discussion will progress. Then we have the Deschardins choledocolithotomy forceps. Although this is used to grasp a stone, the peculiarity is that it doesn't have a box joint. It instead has a screw joint. The reason is you don't want it to crush the stone, because in the CBD, if you crush the stone, there's a tendency for the small fine particles of stone to either go down and cause pancreatitis and more complications. And the second specialty is that it doesn't have any serrations. It just has a hole to accommodate for the stone. And by chance, because it's a blind procedure, by chance, if you grab the mucosa or some other structure, you won't rip it out when you're coming out because you don't have a good grip. So it is used to maneuver into the CBD and remove the CBD stone. Sometimes you can even use it when you're extracting the gallbladder from a laparoscopic port. The stone is too big. You try to remove individual stones before you get the gallbladder out. So like I said, it doesn't have any ratchet. It doesn't have any serrations, and it has a screw joint in order to prevent crushing of the stone and injuring mucosa. This is a Kelly's proctoscope. It has an inner blunt obturator and an outer hollow sheath. Once it is introduced, the obturator is taken off and you visualize the structure through the sheath as you're coming out. Diagnostic uses are, it is used to examine the anal canal and the distal rectum. And therapeutic uses in perianal surgeries, or sometimes if you want to inject sclerosant to the base of a hemorrhoidal pedicle, you can use a Kelly's proctoscope. Now let's talk about tubes. This is a Ryle's nasogastric tube. So make sure you tell the entire name. The specialty about this tube is that it has 3 lead shots at the tip. This is so that on an X-ray, you can see where exactly the tip of the Ryle's tube is because it is radio opaque. Then you have radio opaque lines. You can see there are thin green lines running all over the tube. These are radio opaque, and you can make out whether the tube has gone straight in, whether there is a kink somewhere, whether it is coiled. This can be made out with the help of these radio opaque lines. Like I said, it is made up of medical grade PVC and it is sterilized by ETO. Now, diagnostically, you can aspirate the contents of the stomach for certain tests. Helps you diagnose tracheoesophageal fistula, and in pseudopancreatic test, you can feel for the Ryle's tube over the anterior abdominal wall. This is called as the Bates test. Therapeutically, it is used for enteral feeding. We use it as a feeding jejunostomy regularly after we do a supramajor surgery, and to decompress the stomach. Strict contraindication in trauma patients who are discharged from the nose. Always have a suspicion of CSF rhinorrhea and do not introduce the Ryle's tube because you might end up pushing the Ryle's tube into the cranial cavity. This is an infant feeding tube. Now, the difference from the Ryle's tube is that it doesn't have lead shots. It doesn't have radio opaque lines. This is only used for feeding infants, or sometimes this can be used for introducing a dye and to do an intraoperative cholangiogram. And if you're doing some surgeries on the finger, like a wedge excision, and if you want some sort of hemostasis, you can tie it at the proximal end of the finger and it can act as a tourniquet for the short duration of surgery, whatever you're doing. This is a Care's T-tube. It has an ascending limb, a descending limb, and a transverse limb. It has radio opaque lines all around for us to help us identify the exact position. And this is commonly used in after CBD repairs. Diagnostically, you can do a T-tube cholangiogram through this. Therapeutically, it protects the repair of your CBD by allowing the bile to flow from the ascending limb through the descending limb. And certain surgeons even use this as a feeding jejunostomy tube, where this bit goes inside the jejunum and this comes out through a stamp technique, and the rest of the transverse limb comes out through the anterior abdominal wall. Now, let's talk about the chest drains and the abdominal drains. Now, you can see that one peculiarity is that in the chest drain, the numbering starts from the last hole. The numbering starts from the last hole. You can see the holes are here and the number starts from here, 2, 4, 6, 8, 10. So it means it's 2 centimeters from the last hole and not from the tip of the tube. Then you have radio opaque lines running all over the tube. And please see that there's a hole here and the radio opaque line stops at the hole. The importance of this is that when you insert it as an ICD, a break in the radio opaque line, which you see on the X-ray, will tell you where the position of the hole is. If the patient has surgical emphysema, you don't know whether it is because of the trauma or because the tube has got displaced. So if you see the break in the radio opaque line outside the chest cavity and in the subcutaneous space, you know that means that you have to push the tube in. So it is made up of medical grade PVC sterilized with ETO. Diagnostically, it can help you identify the origin of the contents of the cavity which it drains. Therapeutic is of course to drain the peritoneal and the pleural cavity. And you can even do pleurodesis using this tube. Then we have the corrugated rubber drain. This can come with or without this radio opaque lines. This is again made up of medical grade PVC, and this is used to drain the superficial structures or superficial wounds or surface wounds. Then we have a Foley's catheter. This is made up of either silicone or latex. Okay, and again, this is sterilized by ETO. The full name is Foley's two-way self-retaining balloon catheter. So you have two channels, one channel to inflate the balloon where you inflate distilled water, and the other channel is for aspirating the contents. Similarly, you can even have a three-way tube where one can help in irrigation and the other channel will act as aspiration apart from the one for the balloon. This is a self-retaining Malakoff's catheter. The flower will help the tube stay in place. Again, this is made up of either latex if it is like this, or you even get plastic ones nowadays that is made up of PVC. This is a flatus tube which we don't use often now, but can be kept as an instrument in your examination. This, if it's red, say that it is made up of red rubber. It is not self-retaining and it is usually used to decompress the rectum. It was used for sigmoid volvulus, but it's no longer advised now because of all the hydrostatic or hydropneumatic techniques that we have. Then coming to the BP handle, you have number 3 and number 4. Number 3 basically is for the smaller blades such as 10 to 15, and these are used for fine incisions over the face and the scalp. And number 4 handle are for the larger blades, that is 20 to 24, and these are for the deep, long incisions such as laparotomy. Yes, and finally, let's move on to laparoscopic instruments. This is a Very's needle. We all know that it is used for insufflation of carbon dioxide or to create pneumoperitoneum during the surgery. It has, yeah. So it has an inner blunt obturator and the outer sharp sheath. You can see that the sheath is sharp, and the inner blunt obturator has a spring action. This is because the minute your instrument goes beyond the peritoneum, once there is loss of resistance, the blunt part comes out of the sharp outer trocar to make sure that you don't have any visceral injury when you're using this. Now, when they ask you how do you sterilize it, the first thing that you need to say is you're going to dismantle the instrument, thoroughly clean it before you send it for sterilization by either autoclaving or ETO, whichever is the choice of sterilization in your hospital, and both of them are equally accepted. Then we have the ports. I'm sure all of you are familiar. It's available all the way from 3 mm to 12 mm ports or even larger. Again, this has an inner obturator which you can get with either a sharp or a blunt obturator, and the outer sheath with an insufflating channel which will allow the carbon dioxide to either go in or to come out. Then they have what we call as a valve. There are two types of valves. There is a flap valve and the trumpet valve. Trumpet is like those newer flutes where you press on a button and the hole goes in. So that's where it gets the name from, the trumpet valve. And this is to make sure that once it's only a one-way valve, which only allows the instrument to go inside the port, but doesn't allow the gas to escape out. So it's a one-way in order to maintain the insufflation. Now we have a laparoscopic instrument. Now it has 3 parts. This is the handle, which comes with the ratchet, the finger rings, and the rotation collar. All right. Now the rotation collar is for when you turn this, you can see that, Now when I rotate the rotation collar, you can see that the tip of the instrument is also rotating. Okay, so that is what the rotation collar is for, to make you to turn the insert. Then we have the outer insulated sheath. This prevents dissipation of current in order to protect the port when we are using bipolar and monopolar energy, and also to prevent the burns from the current from transferring along the anterior abdominal wall. Now there are various types of handle. You have the axial handle, which goes along the length of the instrument, or you have a pistol handle like this, where it is at an angle. Like for example, this instrument is a pistol. It's like how you hold a gun. It's like a pistol handle. Ergonomically, they say the pistol handle is better than the axial handle. And the tip and the jaws are similar to that what we use in the open instrument, except they're named slightly differently. This looks like our artery forceps. We call this as a Maryland. This is a tooth grasper or a tooth grabber. This is a Babcock's forceps, very similar to what we use in our open surgery. Now, when it comes to needle holder, again, in handles, you can either get the axial handle. This is also an axial handle with a ratchet and a ring. And you have the pistol handle. They say ergonomically, the pistol handle is better. And between the straight, the axial and the axial handle with rings, this is the axial handle without rings. Sorry, fare better when compared to the ring with the, when compared to the axial handle with the rings. Now
you have 5 minutes to go.
Yes, sir. I'm almost finished. 2 more slides.
Yeah.
So when it comes to the jaw, you have a curved jaw and a straight jaw. Again, it depends on the surgeon's preference. No specific advantage, except depending on the area where you're trying to suture in laparoscopy because of the narrow space. Then you have the self-writing jaw. Here, the peculiarity is that it has a groove. So basically what happens, the minute you hold the needle, it will sit exactly in place. You won't have to flip the needle perpendicular to make it right. So when you hold it itself, it goes and sits perpendicular to your instrument in the jaw. And that's what we mean when we say the self-writing jaw. Now coming to the last slide. I know it's a bit complicated. It took me quite some time for me to understand what do you mean by degrees of freedom. We say that in laparoscopic surgery, we have 4 degrees of freedom. What are these 4 degrees? What do they mean by it? What are the 7 degrees of freedom in robotic surgery? And to make it simple, assume my hand is the port. This is the instrument. If the instrument moves up and down, this is 1 degree of freedom. All right. So the instrument can move in this direction. That's called 1 degree, this axis. If it moves towards the camera and towards me, this is the 2nd degree of freedom. All right. So this is, it's like y-axis and an x-axis. If the instrument moves inside and outside of a port, that is the 3rd degree of freedom. And the last one is if I rotate the rotation collar, the tip of the instrument rotates, and that is the 4th degree of freedom. Don't think this is 5th and all. The circumduction or the circular movement is a combination of these 2 axes. So that is not an extra degree of freedom. So up and down, front and back, 2nd, in and out, 3rd, moving the rotation collar, 4 degrees of freedom in a laparoscopic surgery. In robotic surgery, it's a little more complicated, but it has the same 4 degrees of freedom. But please keep it in mind, in robotic surgery, even the tip of the insert can also move. So that can also move up and down, in and out. So that is 5th and 6th degree of freedom. And it can even turn backwards because it's almost like a human wrist. So it can even turn backwards. So that is a 7th degree of freedom. This might not be the most accurate way of describing the degrees of freedom, but I've tried my best to make it simple so that you understand. We have had a lot of instruments to rush through in 40 minutes. I know it's not ideal, but I've given you the basics for you to build up on. And first and foremost, I'd like to thank Surgical Society of Bangalore for giving me this opportunity to present on such a huge platform. And for all the students, if you have any doubts, you can always put it up on the chat box. Or if you want the presentation, this is my email ID. It's lkanta.57@gmail.com. Please send me a mail and I'll be more than happy to share this presentation with you so that it will help you when you're presenting. I'll stop my presentation now, and I would like to take some comments from the seniors if there are some extra inputs that they can give, which are going to help the students.
I think that was very succinct and to the point, very precise presentation. Excellent, Nishant. I think it's very clear to the students as to what each instrument means.
Thank you, sir.
Sir, material, is it important? Material of the instrument you were talking.
Sir, in exam, when I was a postgraduate student, I was taught to tell the material of the instrument as a part of the viva. They said that it'll fetch a little bit of extra marks. So like I said, most of the instruments we use are stainless steel because they are anti-corrosive and it doesn't rust. If you use any other material, it will rust. So that's the reason we say stainless steel for everything, and invariably we are right.
Yeah. Well done, Dr. Nishant.
Thank you, sir.
Yeah. So we'll move on to the next session, that is Millennium Gold Medal Award papers. Today we have 4 papers. I welcome Dr. Lakshman K, a senior surgeon, and Dr. Shivram HB to judge this session. Welcome, Dr. Shivram sir, Lakshman sir, and Shivram sir.
Thank you. Thank you. If I may come in, I'm sure our consultants who are giving the papers for the award session know about this, but I'm primarily addressing the postgraduates who may be fairly new in giving presentations. When it comes to judging any presentation, particularly for something which is supposed to be an original work as it is in the Millennium Gold Medal Award, the judges take a few aspects for judging. It is done in a very objective